So our third speaker this evening is Dr. Jennifer Brown. We'll just make sure that she is ready. Dr. Jennifer Brown is the director of the Chronic Lymphocytic Leukemia Center of the Division of Hematologic Malignancies at the Dana-Farber Cancer Institute. And she is a professor of medicine at the Harvard Medical School in Boston, Massachusetts. Her interests include the development of novel targeted therapeutics for chronic lymphocytic leukemia, as well as CLL genomics. Her talk this evening will be about updates on therapeutic innovations in CLL. We really would like to thank Dr. Brown for joining us this evening. Dr. Brown, the mic is yours.
Thank you very much for the invitation to speak. Can you hear me okay?
Loud and clear.
Great.
Just wait for your presentation to get uploaded.
Yeah, here it is. So after some discussion, we decided that I should speak about next generation BTK inhibitors in CLL, which I think we'll all be hearing a lot about over the next couple of years. Now, as you're all aware, we now have long-term follow-up of the first generation inhibitor, ibrutinib. This is from the RESONATE-2 frontline study in which ibrutinib was compared to chlorambucil in previously untreated CLL patients. And we now have 5-year follow-up with a progression-free survival of 70%. Yet 41% of patients needed to discontinue the drug, unfortunately, generally mostly due to adverse events. Progressions were relatively rare. And we know that many of those adverse events actually include cardiovascular toxicities. We see atrial fibrillation quite commonly. And in this analysis led by Javed Moslehi's group, in which we participated, we found enrichment for a variety of other vascular and cardiac events amongst patients treated with ibrutinib compared to patients treated with all other drugs recorded in Vigibase. So for example, CNS hemorrhage, heart failure, ventricular arrhythmias, which our group had also reported on from our own experience, conduction disorders, as well as ischemic stroke and hypertension were all enriched in ibrutinib-treated patients. And at ASH this year, we heard data again from the Ohio State group that their series of patients treated with ibrutinib had a very high incidence of new onset hypertension, 72%, and that this was associated with major cardiac events. We also heard from the MD Anderson that in their series of patients treated with ibrutinib, they see significant development of new hypertension in 71% of patients, as well as worsening heart failure, atrial fibrillation, brain hemorrhage, stroke, and CAD, as shown on the left. So it's becoming increasingly clear that ibrutinib carries a variety of side effects that can be troublesome over the long term, especially in our patients. Then once stopped, the median progression-free survival is about 2 years in this patient population from the ECOG study who'd been on ibrutinib for 15 months. So that's really not bad, 2 more years off therapy before progression. But nonetheless, once patients stop the drug, there's steady progression. So what about other BTK inhibitors in clinical development that hopefully might improve on this situation? So first, I'm going to talk about the 2 next-generation covalent inhibitors, acalabrutinib and zanubrutinib. And then we'll talk briefly about the non-covalent inhibitors that have been developed to combat resistance, specifically the C481S or other amino acid mutation associated with the resistance. So if we look at the kinome selectivity amongst the covalent BTKs as shown here, you can see that ibrutinib has a large number of larger red dots, which means it's not very specific for BTK. Zanubrutinib is quite a bit more specific on the left, but acalabrutinib is the most specific. Again, here, acalabrutinib, most specific, does not inhibit EGFR, does not inhibit SRC family kinases, does not inhibit TEC much, which is potentially significant for bleeding risk, and ITK at all, which is potentially significant for combinations with antibodies. Now, in the first phase 2 study with acalabrutinib in the relapsed refractory setting shown here, we saw progression-free survival similar to what we saw with ibrutinib. Specifically, patients with 17p and complex karyotype did have a shorter progression-free survival with median on the order of 2.5 years compared to other populations. The first frontline study in treatment-naive CLL compared two different doses, 100 milligrams BID, which as we know is now the selected dose, to 200 milligrams daily. And they look closely at BTK occupancy in this setting. And as you can see, the BID dosing maintained BTK occupancy much better than QD dosing, particularly at trough time points. The green is the BID dosing versus the orange of the QD. So this led to all patients switching to 100 milligrams BID. We now have 4-year follow-up of this study where the event-free survival is 90%. And this is particularly important because event-free survival includes drug discontinuation as an event. There was, in fact, only a 6% rate of discontinuation due to adverse events. Overall response rate, 97%. And 86% of patients remain on therapy now with 4.5-year follow-up. The first registration trial was in the relapse setting. This was the ASPEN trial in which patients were randomized between Acala to investigator choice of adalimumab, rituximab, or BR. And the randomization was stratified by deletion 17p, ECOG, and number of prior therapies. In terms of patient characteristics, median age was in the late 60s. Patients had 1 to 2 prior therapies, so not as heavily pretreated as some of the earlier studies. And 17p was seen in about 15% of patients. Unmutated IGVH, however, was seen in about 80%. The study was quite significant for its primary outcome, which was progression-free survival. This is investigator-assessed progression-free survival in the final analysis, and you can see that the median for acalabrutinib has not nearly been reached versus 16.8 months for the combination of adalimumab, rituximab, or BR. And on the right, you can see that the two control arms, BR or adalimumab, rituximab, perform really quite similarly to each other in this setting. And interestingly, there was no difference in the acalabrutinib arms shown in purple amongst patients with 17p or without, or amongst patients with unmutated IGVH or without. This suggests that in the less heavily pretreated setting, deletion 17p or p53 mutation is not as adverse as it is in the more heavily pretreated patients. In terms of exposure, the median follow-up of the study at this time was about 22 months, and that was about the duration of exposure of patients on acalabrutinib. And part of the reason the adalimumab rituximab arm probably did not do so well is because of the 11.5-month exposure, with discontinuation of 56% for adverse events. In terms of the events of clinical interest for acalabrutinib, atrial fibrillation was 6% versus 3% in the control arm. Hypertension was 5% versus 4% in the control arm. No real difference in major hemorrhage or infections. So generally encouraging from a cardiovascular and other infection standpoint. The Elevate treatment-naive study is the most recent registration trial. The study enrolled 535 patients with treatment-naive CLL over the age of 65 or younger with comorbid conditions, and were stratified based on deletion 17p, ECOG status, or geographic region, and then randomized between acalabrutinib with obinutuzumab, acalabrutinib alone, or obinutuzumab chlorambucil. And the primary endpoint was progression-free survival between the acalabrutinib obinutuzumab and the chlorambucil obinutuzumab. There was no planned comparison between the acalabrutinib obinutuzumab and the acalabrutinib. And so progression-free survival, as reported most recently with a median follow-up of 28 months, was 93% in the acalabrutinib obinutuzumab arm, 87% in the acalabrutinib arm. And those are both significantly better than 47% in the obinutuzumab chlorambucil arm, as shown here. So perhaps most interesting in these data is the 6% improvement in PFS with the addition of obinutuzumab, which was unexpected based on experience from other studies. And as I said, it was an unplanned analysis, but nonetheless looks meaningful here. Now, if we look at the subgroups, there's generally uniform benefit with the addition of obinutuzumab to Acala, except for the subgroup with IGVH mutation, the mutated IGVH group. This is interesting because the mutated IGVH group often has not benefited actually from the targeted therapy at all as compared to the chemoimmunotherapy in most of the studies. That's true of ibrutinib, for example. And what's suggested is perhaps that achieving a deeper remission for the mutated IGVH patients, similar to what we did with FCR, for example, and what we now do with venetoclax and obinutuzumab, may result in particularly beneficial outcomes in those patients. Events of clinical interest in this study: atrial fibrillation over the 2.5 years is 3.4 to 3.9%. Remember, the obinutuzumab chlorambucil follow-up is only the 6 months on treatment, so it's much shorter. Arguably, the 3.4 to 3.9% is the background rate CLL amongst, of AFib amongst CLL patients based on what we've seen with Tate-Shanafelt's data. Hypertension, again, looks pretty comparable across the groups. There is more low-grade bleeding, but no increase in major bleeding. Some increase in infections, which we always expect. And second primary malignancies, again, it may be the follow-up of 2.5 years. Although we're seeing this in all our studies, ibrutinib, acalabrutinib, and venetoclax, that the rate of second primary malignancies is fairly high in these patients on targeted agents followed over several years. Personally, I think that this is mostly the disease, but it will be interesting to continue to follow patients over the longer term to see what happens with that rate. Now, honing in a little bit more on safety with acalabrutinib, there's a pooled analysis of 9 trials, which should be coming out in print soon. And you can see here that the overall rate of major hemorrhage is 3.6%, which is really pretty comparable to what we've seen with ibrutinib. AFib is 4.4%, which again may be background. There was 1 ventricular tachycardia amongst 1,000 patients, which again may be background. Hypertension was 7.6%, so not nearly as high as what we saw reported at ASH for ibrutinib, for example. And there's actually a study, prospective study, looking at the use of acalabrutinib in patients who've discontinued ibrutinib for adverse events. It's a relatively small study, which makes it a bit hard to interpret because relatively few patients are in each category. But you can see here, for example, that of patients who discontinued for atrial fibrillation, only 3 had recurrent atrial fibrillation on acalabrutinib. Similarly, only 1 out of 7 had recurrent arthralgia. Overall, 62% did not experience a recurrence of their adverse event on acalabrutinib. And with a median of 2-year follow-up, 80% remained on study. Only 12% had to discontinue due to adverse events, suggesting that the adverse event profile of acalabrutinib is in fact better than that of ibrutinib, even in the setting of patients who've already developed adverse events that could be related to the drug. A network meta-analysis of 27 studies was presented at ASH this past December and showed pretty convincingly lower rates of any grade or grade 3 hypertension or any grade or grade 3 atrial fibrillation with acalabrutinib compared to ibrutinib. Ultimately, of course, we're waiting for head-to-head data. That will be from the Elevate Relapse Refractory study, which is a phase 3 study in previously treated high-risk CLL with deletion 11q and deletion 17 and/or deletion 17p. Patients were randomized between acalabrutinib and ibrutinib. And this has been announced to be positive by press release, but we have not yet seen the data. And it was a non-inferiority study from the standpoint of progression-free survival. Our group has explored acalabrutinib in the setting of combination trials, and we're particularly excited about a phase 2 study that we've been doing with acalabrutinib, venetoclax, and obinutuzumab for initial therapy of CLL, as illustrated here. Patients start acalabrutinib a month before obinutuzumab, and then on cycle 4, they start venetoclax after cytoreduction. The primary endpoints at cycle 16, after 12 cycles of venetoclax. Patients who have undetectable MRD and complete remission can stop all therapy. If they still have detectable disease or partial remission, they can go to cycle 25, at which time they're reevaluated and can potentially stop. We reported updated data on this at ASH from 37 patients, 76% of whom achieved undetectable MRD and bone marrow at cycle 16. with 84% in peripheral blood. 11 patients so far have discontinued therapy for undetectable MRD. Median follow-up in those patients is only 4 months, so no patients have progressed, but the follow-up is still very short. But we're excited about this as a potentially time-limited regimen for reasonably fit CLL patients. It served also as the basis of this ongoing randomized phase 3 trial that I'm leading, comparing acalabrutinib venetoclax to acalabrutinib venetoclax obinutuzumab to chemoimmunotherapy with FCR or BR amongst treatment-naive subjects with active CLL without 17p deletion. This is a potentially registrational trial for those combination regimens. What do we know about resistance to acalabrutinib? Well, we do know that of 16 progressors reported by Ohio State University, 11 had C481S mutations and 2 had PLC gamma 2. So it's looking pretty similar to ibrutinib resistance, which is not surprising because the drug binds to the same cysteine, 481. Of 103 patients who were screened, 22 had mutations at a median of 32 months, and then it was about a year to relapse. So data that looks very similar to what they first reported with ibrutinib. Come back to this later. Now, what about zanubrutinib? So zanubrutinib is somewhat less selective for BTK than acalabrutinib. The main point where this may be important is in terms of TEC. It does inhibit TEC rather potently, just as potently as ibrutinib, and that could have effect on bleeding risk. Now, zanubrutinib dosing has been optimized very carefully to try and both attain complete BTK occupancy throughout the dosing interval, as well as to maintain PK levels of zanubrutinib in the blood, so that if there is BTK resynthesis, zanubrutinib is still around to inhibit BTK. And you can see that shown here in terms of even low doses, 40 milligrams or so of zanubrutinib is similar to ibrutinib at 560. Acalabrutinib has an early peak, but then declines very rapidly with its very short half-life. And it's further illustrated here in terms of the plasma exposure, the PK, where in purple is the zanubrutinib at the selected dose of 160 BID, achieving about 10-fold free drug exposure compared to ibrutinib. And this correspondingly shows the very high BTK occupancy with zanubrutinib at the top, ibrutinib at the bottom, and on the right, you can see there's quite a bit of splay downward, which we're not seeing with these next generation inhibitors that were really optimized for occupancy. And zanubrutinib in particular looked at lymph nodes at screening and trough and found that median trough occupancy was still 100% at the BID dosing schedule, which I do prefer because of this better data on occupancy compared to the QD dosing. The phase 1b trial included a significant cohort of CLL patients, which were updated at ASH last year, 123 patients, most of them relapsed refractory, median follow-up about 2.5 years. Median age of 67, 16% with 17p, so somewhat lower than some of the other relapse refractory studies at this point. And as with all the BTK inhibitors, what we see is over time, there's an increased accrual of complete remissions, still going up at month 36 as shown here. And this corresponds also with decreases in PR with lymphocytosis. Progression-free survival looks really good. 2 years is a relatively short time, of course, but 91% in the relapse refractory cohort at 2 years. Adverse events of interest, there has not been a clear cardiac signal in relatively limited patients. The main thing that's been noticeable is that there is more grade 3 neutropenia, although this is mostly an early event, first year, and in my experience is easily manageable with occasional growth factor. Infections were seen in this study as we see in all relapse refractory CLL studies. So the Sequoia study is an ongoing registration trial in the setting of treatment-naive CLL for patients over the age of 65 or otherwise unsuitable for FCR. And the only data that we've seen so far from this are Cohort 2, which was a dedicated cohort of 17p patients with about 100 enrolled, all of whom were treated with continuous zanubrutinib. 109 patients, 14 are off study at the time of this presentation, which was at ASH last year. On study treatment, 95. And the overall response rate had continued to improve up to 94.5% with additional accrual of complete remissions. And the 18-month progression-free survival was 91%, which is really pretty good for deletion 17p patients. Adverse events of interest, again, in terms of grade 3, there were infections, as expected with 17p patients, and neutropenia. Now, we do actually have head-to-head data comparing Zanubrutinib to Ibrutinib, and this is in Waldenstrom's, the ASPEN study. And so here you can see in this head-to-head analysis that Zanubrutinib significantly improved atrial fibrillation compared to Ibrutinib, with trends toward improvement in hypertension, edema, and contusion. You'll note that neutropenia was higher, but pneumonia was actually still less in Zanubrutinib-treated patients. So I think this certainly validates the better safety profile of Zanubrutinib compared to Ibrutinib. And we are, in fact, awaiting data from a similar study in CLL, in which Zanubrutinib and Ibrutinib were the randomized comparison. There's also been a triple drug regimen studied with Zanubrutinib, and this comes out of the Memorial Sloan Kettering Cancer Center. This was a MRD-driven study continuously. So as patients achieved their first undetectable MRD, they just needed to have it confirmed and they could stop. And as a result, 89% of patients have now stopped after a median of 10 months, just 8 months of triplet. And the overall rate of undetectable MRD is 90%. You can see on the right that most patients are in blue, surveillance with undetectable MRD ongoing, although there has been one progressive disease. So it'll be interesting to see how this study with the shorter treatment period compares to some of the studies with longer treatment periods as we get longer follow-up.
Dr. Brown, you have 5 minutes to complete the talk.
Okay. Resistance to Zanubrutinib has also been reported with BTK C481 as well as some Lu528 tryptophan mutations, which are a little unusual, but likely also affect binding. So what about the non-covalent inhibitors? So RTL531 is still in clinical development. It took a long time to get to its target dose, but at that dose, which is 65 milligrams daily, we did see significant partial remissions. And you can see a number of patients are ongoing on study. And I believe this is in ongoing phase 2 trials. LOXO305 is also a potent and selective non-covalent inhibitor, which was reported at ASH. You can see that the kinome selectivity is extremely specific for BTK. On the right, some data from my lab showing that LOXO305 completely inhibits phospho-BTK even at low concentrations in the setting of C481S within patient samples. These are samples from resistant patients. Ibrutinib has partial effect and Acala none. So in the clinical data, 170 CLL patients have been treated, almost all exposed to BTK, about a third exposed to BCL2. About 2/3 came off for progressive disease. Interestingly, only a quarter were found to have C481 mutations. However, these are data that are still pending. They've only evaluated about half the patients yet. So it'll be interesting to see what emerges in that regard. The safety profile is really quite notable. If you look at the incidence of grade 3 and 4 adverse events here, this is across CLL and lymphoma, 323 relapse refractory patients. There are almost no grade 3-4 events, and there were no DLTs. Efficacy also looks very good. Overall response rate of 63% that raises up to 86% in patients on therapy for at least 10 months. There's no difference based on prior therapy, BTK or BCL2, or based on reason for prior BTKI discontinuation. Follow-up is still relatively short, as shown here, but it still looks very encouraging. This is, I think, a very exciting drug to keep your eye on for the future, given its tolerability and its efficacy in these heavily pretreated patients. In summary, Acalabrutinib has demonstrated high efficacy and tolerability with a 90% event-free survival in a frontline cohort at 4 years. The randomized ASCEND and ELEVATE trials have led to the full approval of Acalabrutinib by the FDA for CLL patients in any line of therapy, with or without obinutuzumab. Head-to-head data against Ibrutinib are pending from ELEVATE relapse refractory, and we should hear them soon. Observational data suggests a significantly improved AE profile. Zanubrutinib has also demonstrated high efficacy and tolerability at shorter follow-up, with PFS greater than 90% in treatment-naive and relapse-refractory cohorts at 24 months. Dedicated 17P cohort also looks good. And registration trials are ongoing in the frontline and relapse-refractory settings, with the latter being a head-to-head trial versus ibrutinib. And of course, we've already seen data head-to-head in Waldenstrom's. And then the non-covalent BTKIs have significant activity in patients previously treated with covalent BTKIs. And I would keep your eye on them as we look to the next few years, where these will hopefully become available for our patients previously treated with BTK and venetoclax, and we'll also be seeing trials trying to move them frontline. These are my disclosures, and thank you very much for your attention.